Good morning, everyone. We've got 25 people in the room today. Happy Tuesday. Just so that everyone knows, we will be commencing in a couple of minutes. Today we have the webinar which is being recorded, so it's not a confidential space. This recording will be popped up on the Family Life webinar for people to review after the event. We have everyone coming into this space on mute, and there will be an opportunity for people, one, to write notes in the chat function. So if you're here with us, say hi to us in the chat function, and later on in the conversation today we will go to a Q&A session so that people can ask the presenters a range of questions and get some fabulous responses. So just hang with us for a couple of more moments. We've got 39 people here. We had got about 179 attendees booked in. So we'll just wait for a couple of more seconds. Jan, hello Jan, hello Madeline. We can increase the volume, and if people are finding it difficult to hear, also increase the volume on your laptop or headphones if you're all wearing headphones. For those of you that are joining, just to understand that you'll be on mute. If you've got a question for us, please pop it in the chat function. Who else is there? Good morning, Karen, Kaz Camp. Heifa, nice to have you in the space. Kate Perry, you're in the room. I can see your name on the attendance list. Got 38 people there, and Maria. We're just waiting for a couple of more minutes. Good morning, Ness. Davey. Trini, you're in the room. And Alex Hacking. We'll give everyone at least 2 more minutes before we start. In the space this morning, we've got Christina from AMES. You'll probably see her little face in a box in the corner of your screen. We've also got Liz Perrin from SEMPHN, Ali Tausif from Family Life, and Amanda Morris. So for those that are joining us this morning, just to remind you that we are recording this session and you will all be placed on mute. If you've got anything that you'd like to ask us about this session, please pop your question in the chat function, and we will be using the Q&A facility later on when we've got an opportunity for you to ask questions of our presenters. We will also be doing a poll in the middle of the webinar today to provide you an opportunity to give us some feedback on your experiences during COVID-19 and as we recover. Okay, I am going to I think we should start. Amanda, are you happy with that?
Yeah, let's kick it off, Julie.
All right, just some housekeeping, which I've been speaking to while people have been coming into the waiting room. And Amanda, over to you.
Good morning, everyone. On behalf of Family Life in the lands in which I sit this morning, I'd like to pay my respects to all the individuals who make up our organization and respectfully acknowledge all Aboriginal people, past, present, and future, and their ancient and ongoing connections to culture and country. In particular, the Boonwurrung and Wurrung Wurundjeri people of the larger Kulin Nation, whose ancestral lands Family Life provides services across. We acknowledge that this land is a place of age-old ceremony, celebration, and initiation. We recognize that the living culture of the Kulin Nations has a unique role in the life of this region. As we share our own knowledge practices within Family Life, we pay respect to the deep knowledge embedded within the Aboriginal community, their relationship to country, and the spiritual connection to the land. We commit to working respectfully in honoring and learning from the ongoing connection to traditions, culture, and country. Next slide.
So thanks, Amanda. We're very privileged to live on Bunurong and Boonwurrung land, the land by the sea. So always fortunate to acknowledge the country that we're on. So this slide is just a summary of what we'll go through this morning. It speaks to a range of things that the presenters will be talking to, including the emerging themes that the three organisations have observed in their work. There'll be a fabulous video that's been produced with staff and clients of the Connect Shine program. And then we'll be wrapping up with some practical approaches to support CALD community members moving forward. There'll be a Q&A session at the end, and we hope to have you out of this session by 11 a.m. Now, I'd like to just introduce Amanda Morris, who's the Program Manager for Family Safety Programs and Services with Family Life. Amanda's been with the organisation, I think, Amanda, for about 4 years, and has extensive experience as a social worker working with trauma-informed practices, working with adults and young people, and in supported accommodation, residential settings. She's a consummate professional and gorgeous soul, and I'm very excited to throw it over to you, Amanda.
Thank you for that really lovely introduction, Jody. And welcome to you all to Family Life Supporting Mental Health in CALD Communities during and post COVID-19, our community of practice. This webinar responds to our experiences as organizations and practitioners working with and supporting clients during COVID-19. A special welcome to all of you joining today. And as Jody said, there will be 174 people joining this webinar, which is really exciting and a real honor. I'd like to introduce to you now our presenters for this morning. You will meet Christina. Christina is a qualified social worker, child psychotherapist, and mental health clinician who is currently working as the team leader at AMES, Australia Humanitarian Settlement Program, or HSP, which provides settlement support to newly arrived refugees. Then we've got Liz. Liz is the lead for access and referral at SEMPHN. Liz has worked over the past 20 years and has been strongly influenced by the completion of her Bachelor of Social Work. She's enjoyed many challenges and learnings while working with individuals and families within disability case management and her roles in mental health intake and support through the Southeastern corridor of Melbourne. And welcome, Liz. And Ali. Ali has been a team leader at Family Life's mental health services with Shine and Connect for the past few years. Ali has a postgraduate in community services with 17 years of experience in the community services sector. Thank you so much, all of you, for joining us and contributing your knowledge this morning. Next slide. So we're going to discuss this morning few emerging themes from 3 of our organizations working in the CALD communities during COVID-19. Next slide. As professionals in 2020, many of us became familiar with a number of catchphrases that became popular over the course of the pandemic. Things like Zoom or Microsoft Teams, which lovingly leads me to my favorite, "You're on mute." We all became familiar with the concept of social distancing and toilet paper flying off the shelves. We can have a laugh about these things now as we come out the other side of the global pandemic a year later. But when we were in the thick of it, many of us can reflect on the challenges that were placed on our mental health as these new concepts were introduced. Upon reflection, in many ways, it's a shame that there was such little coverage or proactive resourcing for the ramifications COVID-19 had on our mental health. Common consequences of crises on individuals include anxiety and panic, depression and anger, confusion, uncertainty, financial stress, all of which estimates between 25 and 33% of the community experiencing high levels of worry and anxiety during past pandemics. That's relatively high, or it's a relatively high number, excuse me, to not acknowledge the mental health crises that was occurring alongside the recent pandemic. Present for us and our clients and some of our loved ones were words and phrases like the decline in resilience or surge capacity, and of course, the elephant in the room that brings us here today, mental health. These were all just as present in 2019 as were face masks and social distancing and even the toilet paper, but aforementioned as much as they should have been in the media. When we look at the term resilience, it's the experiencing a trajectory of consistently few symptoms or problems with minimal elevations limited to the time during the trauma and its immediate aftermath. When you look at the topography of the journey to date, there are highs and lows in our responses and emotions as communities, organizations, families, and individuals across the stages. Each of us will be able to identify and relate to different stages and associated behaviors as we have navigated working through the pandemic's unpredictability. Take a moment to look at the graph on your screen and reflect on where you feel you were placed. As I mentioned, some of the situations below. We'll go with a simple example. Working from home and making that change to work from home and working online and working on Zoom, for example. Then you have working and parenting from home for some of us. Where does that place you then? Then we had working, parenting, supporting children with at-home learning from home. And for many of us, it could be living at home during isolation. The experience of it is not sequential and linear. The emotions and behaviors we observe of others or felt ourselves may have felt scattered. Yet many of us continue to put the same pressures and expectations on ourselves as professionals to continue to support our clients who were struggling, as we ourselves were too personally. I'd like us all to collectively take this moment in this community of practice this morning to really allow ourselves a moment to acknowledge how far we've come through a global crisis as a professional, as a person, and as a sector. I'd like to thank you all for your unwavering support that was consistently offered to the community over the last year, regardless of circumstances. It's truly something to be proud of. We have and will continue to experience peaks and troughs. We're not out of this yet, but remain in this together. Continue to remind yourselves that you cannot pour out of an empty cup. Thank you all for being here this morning. Next slide. Before we get into the community of practice, I'd like to begin with some contextual statistics to help wrap your brain around just what we are discussing today. I'll start with some global statistics and move into some tangible findings from our experience at Family Life as a comparison. Our guest speakers will then share their experiences with you. As at 2019, Australia's population sat at 25.36 million. Australia's population includes many people who were born overseas, have a parent born overseas, or speak a variety of language. Together, these groups of people are known as culturally and linguistically diverse, or CALD populations. In Australia, CALD populations represent around 1/3 of Australia's population. Next slide. According to the 2016 census, nearly half of Australians had been born overseas, or at least one of their parents have been born overseas. It is estimated that around 500,000 people have been part of the Humanitarian Visa Grant Program from 1977 to 2019. Next slide. At Family Life, we have 2 mental health programs that have supported community over the global pandemic. Our support, help, information networks, and SHINE or an education or SHINE program provides early intervention and preventative mental health support in universal and community settings through both outreach and school-based activities designed to interrupt the progression of emerging and enduring mental illness for children and young people. Our Connect program is a free peer support service that puts people who live, work, or study in Victoria's Greater Dandenong community in touch with mentors. The peer support model provides support to individuals whom they share similar experiences. The Connect program is funded by the Southeastern Melbourne Primary Health Network. The peer support program is available for people 16 plus, with services available to individuals from CALD backgrounds, and our mentors speak a range of languages, including Arabic, Dari, Farsi, Persian, and Urdu. Next slide. During COVID-19, the SHINE program completed 202 safety audits of clients actively participating in services between the 30th of March and the 5th July 2020. 81% of safety audits were completed over the phone, while 19% were completed during or by video conferencing. Emerging evidence shows a significantly high medium risk in relation to mental health concern, isolation, family violence, and child welfare concerns. Next slide. 39.4% of the Connect client population completed a survey identifying their cultural background. Of that, only 3 identified as CALD, while the remainder preferred not to identify or did not identify. Our client population predominantly resides in the Greater Dandenong area, with few residing in Casey. The Connect program completed 20 safety audits of clients actively participating in service between 30th March and 5th July 2020. Emerging evidence shows significantly high medium risk directly related to relationship concerns, mental health, and isolation. Next slide. Previous research has pointed out that low proficiency in English, separate cultural identity, loss of close family relationships, stress of migration and adjustment to the new country, limited knowledge of the system, trauma, exposure before migration, racism, and limited opportunity to appropriately use occupational skills are contributing factors to increased risk of mental health issues in CALD communities. Within CALD communities, refugees and asylum seekers are at a greater risk of developing mental health problems and suicidal behaviors, as they are exposed to additional negative experiences, such as prolonged detention, human rights violations, exposure to violence and threats, ongoing temporary protection visas, and experience of trauma. Next slide. Generally, immigrants, refugees, and asylum seekers have lower rates of mental health service utilization than the Australian-born due to the stigma, limited knowledge of the services, quality of care received, communication difficulties, confidentiality concerns, and lack of trust in service providers and service discrimination. The COVID-19 pandemic has amplified some of the existing barriers for CALD communities due to challenges in access to accurate, timely information, disruption in trusted community networks, and lack of culturally responsive mental health services and supports. Next slide. Recent studies on the impacts of COVID-19 highlight that around the world, COVID-19 pandemic has exacerbated pre-existing health, social, and income inequalities for already marginalized groups, such as immigrants and those with temporary visas, communities of different backgrounds, people with financial constraints, homeless, and people with a disability. In particular, people with anxiety-related or mood disorders. It has been suggested that individuals previously exposed to traumatic events, and particularly to continuous traumatic stress, may be more vulnerable to distress related to COVID-19. As promised, our panelists will discuss their experiences and emerging themes as they work through the pandemic. Next slide. I'd like to introduce you to Christina. Christina, please go ahead.
Thanks, Amanda. Good morning, everyone. My name is Christina. So I'm the team leader working at AMES Australia under the Humanitarian Settlement Program. Next slide, please, Jodie. Next slide, please. So I'm the team leader in the South and Eastern region. So I would like to start with a very brief overview of AMES Australia and HSP program. So AMES Australia has been providing settlement services to newly arrived refugees and humanitarian entrants since 2005. So between 2005 and 2011, AMES Australia delivered the integrated humanitarian settlement strategy and assist almost 20,000 clients to settle across Victoria. So the new HSP program is replacing the IHSS that we had between 2005 and 2011. So from 2011 to July 2017, we start delivering the Humanitarian Settlement Service, which is HSS program funded by Australian government. So the HSP program, which is where I'm currently working at, has a particular focus on supporting clients to achieve their positive outcome regarding education, employment, and English language learning as a key driver of social and economic well-being. So in the South and Eastern office, we have 7 case managers, 3 senior case managers working under the holistic approach, which means we are not just looking at the settlement aspect of the client, we also look at the social, mental, and physical aspect of the client. Also, we're working under the guidelines of strengths-based and person-centered. So during our intervention, providing services, we put the client in the center of our practice. So next slide, please. Yeah. So who are eligible for HSP? We have 2 different services. The first one is what we call Tier 2. So that's in general the refugee categories, sub-visa 200, which is people who the UNHCR has referred to Australia for resettlement. 201, visa type of 201 is in-country special humanitarian visa. So that's for people who are still living in their country and have been unable to leave. We also have 203. It's called emergency rescue visa. It's for people who the UNHCR has referred to Australia as they are in immediate danger. 204 is women at risk. It's for women who do not have the protection of a partner or relative and are in a danger situation. And the most common one during this COVID is Global Special Humanitarian Visa, which is subclass 202. So we have a case manager supporting this type of visa newly arrived refugees from day 1 up to 18 months after they arrive in Australia. Like I said before, supporting client looking under the holistic approach, we are not just helping them with the settlement, also we're looking at all the physical, mental health aspect of the client. And also we have a specialized intensive services, which is called Tier 3. So a senior case managers will be assigned to this type of visa. So under the Tier 3, the clients usually presents one or more complex needs. It can be mental health needs, housing, physical needs. So if it's approved by the department, a senior case manager will be working with these clients up to 6 months, subject to the approval of the department. So who under this specialized and intensive services, we have protection visa subclass 866 and temporary protection visa 785. But if you come across any clients presents to be having more than one issues or concerns, and you think there will be benefit from our specialized and intensive services, you can actually make a referral directly to the department, and after the department approve, and we can start working with the client up to 6 months. Next slide, please. So I just want to quickly touch base on the client cohort in the Southeastern region. AMES Australia HSP program, we have 3 main offices operating in Victoria, so in Melbourne. So we have a Dallas office looking after the clients living in the north suburbs, and we have a Footscray office looks after the west suburbs. So myself is working at Noble Park office. So Noble Park covers both South and Eastern region. So it's a very large catchment area. For the Eastern region, we cover up to Chingside Park, Mooroolbark, Croydon, Ringwood. For the South region is for both City of Dandenong, Greater Dandenong, and City of Casey. So all the way down to the Pakenham area. So the main client cohort in the Southeast regions are Iran, Afghanistan, Burma, Syria, Myanmar, Somalia, Pakistan, and Iraq. So next slide, please. So after the video, I will talk a little bit more around the mental health and also like the referral pathways for under the HSP program. Thanks. Thanks, Amanda.
Next slide. I'll now introduce you to Liz, and Liz will talk to their experiences at Perrin.
Thanks, Amanda. Good morning, everybody. As I've already been introduced, my name is Liz Perrin, and I'm from Southeastern Melbourne PHN, or as we're often known as SEMPHN. So I apologise for the acronyms this morning. We seem to be loaded with them in this industry, but I'll try and ensure I explain them before I use them. But next slide, please, Jody. Take that face off there for now. Thank you. So I just wanted, it's very formal, that photo, so it doesn't feel real sometimes when I look at it. I just wanted to start with who we are. I know some people will know SEMPHN pretty well and will have worked with us in the past, but also some people in the audience, I'm not sure, may be saying, who are PHNs and what do they do, primary health networks? So I just wanted to start with some information there. As you'll see, no matter where you live in Australia, there will be a primary health network, a PHN, that looks after the catchment area in which you live. Within Australia, as it says, there's 31. Within Victoria, there's 6. So when you think of the size of Victoria, it doesn't feel like many. So in regards to Southeastern Melbourne PHN, we cover about 1.5 million residents, as it says there. And that really covers the area from Port Phillip, so right into St Kilda and nearing Melbourne, right through to Cardinia Shire. So as Christina said, Pakenham and Cooey Rup, so out that way. And then we cover right up to the Mornington Peninsula, the beautiful areas of Frankston and Mornington Peninsula. So it's a pretty big area in which we cover. We also, Greater Dandenong, as the others have described, has the greatest number of people, probably just under 21,000, who within our stats are described as or have described themselves as being born overseas who speak English either not well or not at all. And we all know that there's several factors that contribute to an increased risk of mental health in our CALD communities. I think Amanda has already touched on those, and they were the examples of low proficiency in English, for example, low levels of health literacy, which is a big one for the primary health networks. It's all about inclusion and ensuring people are getting the right service at the right time, and ensuring that our commissioned services, as it says there, we don't provide service directly. We commission services out to providers within the local community, either health or welfare community agencies, who can then provide that service to the community that they know. So best fit for the individuals that they look after. I think Amanda also touched on the health system is often not designed to support the diverse needs of people from CALD communities. She expressed that really well, I think, in her slides. And this is unfortunately shown in many of the mainstream services really being underutilised by the CALD community. Next slide, please, Jodie. So really there, it's just focusing on what I've already described. It's really about increasing effectiveness and efficiency of services for everybody, including our CALD community members who may be falling through that safety net of other services. And it's about providing the right care at the right time in the right place, specifically perhaps for a CALD community group that's within a specific LGA. So it's about really tailoring that service to meet that community's needs. Next slide, please. And as it says there, we don't provide the services directly ourselves. Our role is to ensure we commission out those services to primary health and community agencies located within specific communities. Next slide, please. I just wanted to have an overview. As my intro said, I work within the Access and Referral team within SEMPHN, and my role there is as lead. So I just wanted to give a brief glimpse, and I'm sorry there's a lot on this slide, but really what I wanted everybody to be able to take away from this is we work and we provide those commission services right from our step care model of people who are quite well and being able to link them perhaps to a digital or low intensity service where they can have some support provided, right through to our middle range, our low to middle range. Our low range would be the service that we work with Family Life, our peer support Connect program, through to some counselling support, right up to what I call the pointy end of support services in primary health. People that require, usually have they have a diagnosis of mental health. They've probably been in and out, unfortunately, of the mental health services and system in tertiary and primary, and they are that one step away, I suppose, from tertiary and needing some more intensive support. So it really, this step up and down, its aim is to ensure that we're all communicating well with each other, and with client consent sharing the relevant information, so consumers don't have to do that thing of retelling their story all the time and or going in a great search for the next step up or down of service support that they need. I think that's all I probably would need to say there, Jodie. Next slide, please. So I'm just going to talk just briefly and then get on to what we are seeing about the Access and Referral team, the team that I work in. So briefly, we receive the referrals that come in for our commission services across our 10 local government areas within mental health, as well as a couple that we see within the alcohol and other drug support services. And our role is really to refer people to the, as we said before, the most appropriate services, or if they're not one of our commissioned services, to ensure that they're linked or redirected to another support service. Sometimes people ring in and really the priority issue at the moment, even though they have mental health issues going on, as you all would have in your services, they might need something such as housing or even, you know, food and support. So it's about being able to have that link to our community and know the other services involved. The team is made up of mental health clinicians. We have mental health nurses, OTs, psychologists, and social workers within our team. And it's really about completing that initial assessment to assist consumers to find that right service for them. Next slide, please. So this is the important one. What are we seeing? So within our service, as I said, we're often the first point of call. We don't see people for a long time, and we only speak to them over the phone, really, or receive their referrals in from the referrer. So what we've seen really is an increase in calls from consumers with complex presentations. So we've seen, as the others have mentioned, anxiety and frustration, which is sometimes expressed as anger due to the extended lockdown in particular during that time. And those stresses, I suppose, are exacerbated, as we touched on earlier, by the impact of a person's health, such as the low levels of literacy, reading and you know, being able to access the information about COVID. Those feelings again were exacerbated, as the second point says, by not being able to continue with work and study, to continue with people's normal routine, which helped them with a lot of the past trauma that they had experienced in the past. And now that day-to-day routine has been upended. As it says there, point 3 is about family. So we know our CALD community, the extended family, is very important, whether they were overseas and they had concerns about the countries that they were in. That was increasing that re-trauma in a lot of instances. And also there was that also disconnection from their extended family that might be in Melbourne or in regional Victoria that they couldn't see, and often this was their only or main support. So there was that real impact in regards to concerns for their other family members. And then point 4, it looks at most of our consumers, particularly within the CALD community. We do look at a lot of, such as Ellie's service that he'll talk about later, or program. They mainly contact us or can contact us by walk-ins, by word of mouth, by other people that they know, and by seeing somebody face to face and pretty quickly. So all of a sudden we went from that to everything being telehealth, particularly in that lockdown time, which was often unsettling. And it was also those issues that Amanda, I think, mentioned before in regards to trust and feeling comfortable with services. Even though we're not a Commonwealth or we're not a government service, we're often seen as linked to that, which has a lot of trust issues in itself to begin with. And the last point there, the need for referrals to be processed quickly versus the increase in demand for services. So there was definitely a change there to ensure clinicians felt that they could still complete a comprehensive referral, that they were caring for the people that they were speaking to, versus that real increase in demand that we were having. We still had the same number of staff and also the complexity of each call. So I think Amanda again touched on the real impact on staff during this time, as well as referrers, as well as obviously our consumers, but ensuring that we can provide that service and meet the needs when capacity all over was very high, and finding supports for people was getting quite challenging versus the number of referrals that were coming in. So that's it from me. Thank you.
Now we've just got a short video clip that goes into a bit of detail about the Family Life Connect program, and we have staff and clients in the video who experience outlined their experience engaging with the service and during the pandemic. So please enjoy.
My role as a peer support worker is mainly about providing mental and emotional support to eligible community members who experience low to moderate mental health issues.
I started working as a peer mentor worker since May 2017. Normally we work with refugees and CALD communities.
We have the opportunity to support them emotionally and link them to the other services if they need. The Connect program is not a medical model, it's a social model, and I just provide emotional support for our clients.
مخصوصاً اون شوک فرهنگی که به من وارد شد به محض ورود به استرالیا، چون از نظر فکری، فرهنگی، قوانین خیلی متفاوت بود با جای قبلی من و من نیاز داشتم که کسی یا کسانی این تفاوت رو برای من توضیح بدن و به من کمک کنن که من مچ بشم، آداپت بشم با این تغییراتی که ایجاد شده.
CALD communities usually face many challenges due to migration and related issues such as employment, cultural differences, social and economic difficulties, lack of access to supportive networks, and also language barriers.
خب لاکداون بود، مثلا ما تازه اومده بودیم، اول زبانو بلد نبودیم، یعنی لیسانس نداشتیم، موتر نبود که ما جای بلد باشیم، کورسای زبان همه بسته بود دیگه، دوکانا همه چیز بسته بود و ما یک حالت بسیار، یعنی تقریبا به دپرشن و به چی، چون با وقت لاکداون ما آمده بودیم اینجا دیگه. پارک برای اطفال بسیار چی بود، مشکل بود، به داخل خانه بودن، مثلا به پارک اینا نمیتونستن برن، حال شهر بازی و اینا خیلی مشکل بود بر ما، مشکلات خود داشتیم.
COVID-19 was not clear for everyone. It was a crisis for everyone, not just for the CALD communities or for anyone who reside anywhere around the world. There is a fear when it's going to end, how it started, how we can protect ourselves and from the pandemic.
الصعوبات اللي واجهناها بكوفيد 19 هي انه لازم نتحداها هذا الفيروس، وانه نعمل بتوصيات الدولة اللي يعني اللي لازم نلتزم بها، ومن خلال اتصالات ست وفاء دائما انه تنطينا يعني انه الامل، وانه ان شاء الله يعني تكون بكره احسن، وان شاء الله لازم نتحدى هذا الفيروس، وانه نشغل نفسنا بغير اشياء، ونكون يعني ما نفكر به، يعني يعني نفكر به اكثر من يعني من اللازم.
Personally, I found that people and myself struggled because we are human. We need to interact with each other.
خب اون یک چالش عمومی بود، در واقع مختص به من نبود، اینکه ما مجبور بودیم توی خونه بشینیم، اقامت کنیم و جایی نریم. خب من عادت نداشتم به این قضیه، چون کلاً اکتیو هستم، زیاد بیرون میرم، اسپورت میرم، ورزش میکنم. خب این برای من یه مقداری از نظر روحی و روانی خسته کننده بود، هم من برای خودم هم برای خانمم. جو خونه سنگین میشد چون عادت نداشتیم به این قضیه.
they feel like they're really connected to someone who understands their culture, and there's no much barrier, but we still have professional boundaries. So we make sure that help them to understand their own situation according to the strength-based approach, and link them to the other services based on the client-centered approach.
کلاً من از زمانی که وارد استرالیا شدم از این سازمان هر جور که شده استفاده کردم و کمک گرفتم، چون از ابتدا اون حس اعتمادی که به این سازمان داشتم و این حس رو سازمان در من به وجود آورد، مخصوصاً حالا با اون شخصی که من در ارتباط بودم، آقای عتیق، خب خیلی به من محبت داشتن و تقریباً پشتوانه روحی و روانی من بودن تو این مدت. هر وقت که به مشکل خاصی برخوردم به سازمان رجوع کردم و با عتیق جان صحبت کردم و مشاوره گرفتم.
I'm very fortunate to have this opportunity through working as peer support worker to reach out through the Connect program to contact people, and most of them were vulnerable in our community, and give them the opportunity to feel that they are not alone.
اولین چیز آشنایی با خانم منیره. از بهترین چیزایی بود که من وقتی امروز از اینا گپ میزنم بسیار احساس آرامش، بسیار یعنی خیلی خیلی آرومم. فکر میکنم حالا یه عضو از فامیلم، خانوادم با من صحبت میکنه، خیلی یعنی حرفایی میزنن منو آروم میکنن دیگه، حرفایی میزنن که من راجع به قانون اینجا بالاخره هر وقت یه خبر میشه از لاکداون از اینا منو به جریان میذارن که یعنی حالا این شرایط اومده تو با خبر باش دیگه. از همه چیز یعنی چجوری خودم رو بسازم، چجوری اینجا یعنی چجوری راه بیفتم، چی کارایی رو یعنی من از اول شروع کنم، تشویق به از اینکه من زبان یاد بگیرم و مثلا همین چیزا با اکسرسایز کردن، با کارهای خوب و چیزایی که من خود خوشحال میسازم میشه اینا با من صحبت کردن برای من کمک کرده خیلی.
We used to see them face to face. So the reaction we can see from the face and how we can help them, because sometimes the word doesn't express the feeling.
البرنامج اللي ساعدني بصراحة إنه انطاني أهم شيء الثقة بنفسي والأمل، وإنه بكرة أحسن من هاليوم، خلاني انه اقف مره ثانيه انه اتعدى هالصعوبات، ولازم اكون الخاطر الناس اللي تحبني، والخاطر هالمنظمه الحلوه اللي موفرتنا يعني الكلام الحلو والثقه، ودا يتعبون ويانا انه نكون احنا احسن وافضل. فلازم نتحدى يعني هذه المشاكل وهذه الشيء، ونقف مره ثانيه ونحس انه بكره احسن بكثير.
We are a multilingual team and we are dedicated and our services are free. So any person who likes to access our service will be welcomed and supported in any way we can.
We need more public awareness about mental health in the community, especially CALD community.
Tell the communities, the CALD communities, to join this program. It's very flexible, it's easy to access, and there is no complexity in referral process. Just join the program.
We can go through this, but together. We need to support each other.
أحب أقول لهم إنه شكراً جزيلاً إنه على تعبهم، على اتصالاتهم، على إنه يعني يسمعون مشاكلنا، وإنه يحاولون إنه يطورونا نحو التقدم، ويعطونا الثقة والأمل، وإنه بكرة أحلى من هاليوم. هذا الشيء الحلو. شكراً جزيلاً.
و هم اینکه این دوران رو ساده تر ازش عبور کنه. خیلی ممنونم از ایشون و خیلی متشکرم از سازمان.
I'm really, really happy with Connect program. Yes.
Thank you, everyone. If I can get everyone to turn your attention to the chat function, and forgive me, this is probably the first time I'm doing this poll. We've got a poll section here that's going to ask a couple questions. And it's your time to get a bit interactive via the questions and use the opportunity to reflect on your experiences and answer as honestly as you can. There we go.
So if everyone can, oh, we've got,
there we go.
Yep, great.
Well, it's looking a bit tight there, question one.
Amanda, it's really interesting
Okay.
looking at the re-traumatization percentage.
Yes, that's probably something I'd love to unpack in the Q&A section.
Interesting that to what degree has COVID-19 impacted your work? Whether it's a very minute difference between moderate and large amount. We won't have time to unpack that today, but I'd love to understand the what that was about. What, yeah. So 41 of 50, 42 people have responded. So we'll give this one more minute. I think it's great for understanding the impact of COVID on people and clients. Very high level feedback. So Amanda, is everyone, I think we'll end the polling now and then we'll move back into the presentation.
And if there are anything or if there is anything that's come up for you filling out that poll and you have any questions for the panelists, feel free to drop that into the Q&A section at the bottom of your screen or into the chat, and we can definitely hopefully unpack that later.
So I'm coming back to you, sharing. Driving my DJ platform back here. Right, back to you, Amanda.
Thanks, Jodie. So we'll have our panelists, our three panelists now discuss the practical approaches to supporting CALD community and what they've done to tailor their practice from what they knew to what it is now to support the ongoing challenges of COVID-19. So Christina.
Thanks, Amanda. Right, so before I start, I just want to touch base on some key mental health symptoms that we found with refugees, especially under the COVID-19. So the most common one is PTSD, post-traumatic stress disorder. What we found is the carry-on trauma from their previous experience to actually exaggerate a lot more during the COVID period, and also the major depression and anxiety. Panic attacks. I guess panic attacks is associated with, because there is a lot of a lot of restrictions under COVID, say just simple things like to buy a MyKicker. If the client, like we are unable to support the client face to face, to help them, teach them, educate them how to get the public transport, how to get a MyKicker. But this small event will just trigger their panic and also like the existing mental health concerns, and also adjustment disorders, grief and loss. So the main approaches that we do under this COVID was, there are three main approaches that we HSP team working with clients. So first one is recovery oriented approach. So shift from the traditional mental health treatment, which is a disease focus or what we call medical focus approach, that we will just focus on the disease, make the referral, liaise with the doctor, but focusing on the disease. We shift from that model to a recovery oriented model, which means we're looking at the recovery aspect of the client. So under the recovery model, we are operating under the 5 domains. The first one is promoting a culture and language of hope. So this one is actually associated with strengths-based approach. So we are communicating with clients through the telephone with a sense of hope. So we're trying to encourage the client to stay positive, and also we case managers explore some online mental health support events, workshops, and send the link to the client for the client to keep their mental well-being well during this COVID that we can't see them face to face. The second domain is person-centered and holistic. So we put the client in the center of our approach and make sure they get informed consent if any treatment or if any referrals to be made on their behalf. So case managers usually give the client a call, explain what sort of referral might benefit their recovery, benefit their mental health, and seek their opinion. Again, all the activities, referrals are based on the person-centered and holistic. So we are not just looking at the mental health, and also we link the client with a range of community services like church, like their local groups, English conversation groups, although it's all through online, but that really helps the client to engage with the larger community. The third domain is supporting the personal recovery. So this is individualized care plan. So case managers working with a client by planning the individualized mental health care plan or mental health support plan. So we understand every individual is different. So we make the referral based on the individual needs, and all the referral pathways obviously will be communicated with the client beforehand. The fourth domain is organizational commitment and our workforce development. So organizational commitment is I make sure like we have a program, we create workplace culture, which is supporting the recovery, create a safe and secure space for the client to talk to us freely about their mental health concerns. And also we practice non-judgmental in the organization and make sure the client feeling safe when they are telling us or disclose any sensitive matters. The last one is action on social inclusion. So we actually, in partnership with such as Family Life, with Foundation House, with a range of mental health headspace, a range of mental health support services in the Southeastern region, with the aim to with the purpose to promote social inclusion, because during this COVID, we really discovered that there's a range of issues that mental health issues with the CALD community that we can work on. So promoting social inclusion is not just, simply like providing an interpreter, accept the diversity. It's more about understand their experience, understand what they have been through, and also we have the patience to listen and stay with them. So that's what we do under the recovery oriented model. There are a couple of things arise from the COVID, under the COVID for our clients. The first one is unreported mental health issues, because since last year, March, the case management team is working remotely, so we're not seeing clients face to face. Because of that, a lot of unreported mental health, and we found it's so difficult. Like what Manira said in the video, we used to see clients face to face, and we can observe the family environment, we can observe the body language. But because now we're seeing clients remotely, that can actually pose a lot of challenges to discover their mental health concerns. And also the social stigma is still there, that we found that most of the clients are still hesitated to disclose their mental health concerns to outsiders or people outside of the community, with having a fear that the stigma will impact on the client and their family. And the second challenge that we have experienced is building up the relationship. As we know, mental health recovery is a long journey, and it's not easy for someone to just disclose that to someone from from an outsider. So it's actually need to take a long time to build up the relationship with the client, build up a trustworthy working relationship with the client. But under COVID, it's quite difficult, because we can only contact client through telephone. And for the first 6 months of COVID start, our main focus is provide education to the client about the restrictions, about what they can and they can't do. And this was our main focus. So that actually impact on our relationship, like building up the relationship with the client. I guess the very last point is we're working under the psychosocial approach. So we're looking at the psychological needs and the social needs of the client. As we know, the Maslow hierarchy, we're looking at the very basic needs of housing, food and everything as a very basic human needs, and then start building on that. But we found under COVID, it was quite difficult for us to work on that. It's just because supporting client remotely can really impact on the relationship, the communication, and also the amount of information the client willing to disclose with us. So that's just some challenges for us under the COVID. Next slide, please, Jody. You're right. So very last, I just want to briefly to touch base on how we, as a case management team, how do we determine the mental health needs and what the referral pathways for us. So we'll first conduct an assessment and to determine if the client's got immediate risk, which is mental health crisis at the risk of harm or to self or others. So as a settlement services, we are not mental health specialized services, but we are mandated to report, to make the referral. So if the client's at the risk of self-harm or others, we will make referral to the ambulance. Police will contact the CAT team directly straight away. If the client's not at the immediate risk, just go back to immediate risk, and also we'll conduct risk assessment to determine the needs with the safety plan. If the client's not at the immediate risk, what we'll do is there are a range of things that we'll do. Normally we'll make a referral to the GP, get the client to consult with the GP, and also make the referrals to the community mental health services like Family Life Sham program, Connect program really helps us with our clients. Headspace, Foundation House, so all these counseling services will help the client in supporting them for long term. So this is basically just how we support the client and determine their risk of mental health. And sorry, next slide, please. Okay, so I'll leave the question time to the end. Thank you.
Ready for your section, Liz?
Thank you. I'll just, I might start on the next slide, please, Jodie. Just reflected more so on our access and referral program in SEMPHN, but also SEMPHN as a whole. And I'll just go through these points quite quickly. I want to ensure that we get to Ali and hear about his fantastic program, particularly after seeing that great presentation that his team gave. So thank you for that. I got a little bit emotional watching that. It's very powerful. So congratulations on that. And I'm doing it again now, so I better quickly talk about this. I just wanted to relate, and a lot of the things Christina has already said. So really awareness and empathy, which I'm sure we all do, but it's about being able to ensure and remind ourselves of that during this time. And I think mental health stigma is a big one here. I found even the use of that term mental health sometimes. I know with Ali's team, we really started on using alternative words when we're speaking with certain consumers, such as overall well-being, good health, stress, rather than using that term mental health to begin with. Also, the second point there, acknowledging the individual's current situation, the re-trauma and the normalisation. So normalising certain parts that we are all going through, but also their individual situation. I think with the re-trauma, it's a big point for my team, or our team, only because we often work with people for a very short time and it's over the phone. So we may only speak to somebody for 35 minutes to an hour. And so although the clinician may use trauma-informed practice, they're very aware of triggering information, because they're not providing that future support. We're linking that person on with a new service, with a new clinician that they'll speak to. Therefore, they're mindful of gaining an understanding from the consumer of their situation, and for the consumer definitely to feel listened to, but the consumer has to be, or the clinician rather, has to be sensitive to the consumer's needs without asking too much because of that limited time that we have. So that's a real challenge during COVID. Point 3 is really about, as Christina said, building those strong partnerships and connections with other services and supports. We definitely do that with Family Life, with our local council services and supports, AMES, local smaller services like Wellways for Women and refugee community health services are great. I recently read an article in relation to working with CALD communities where I think they reminded me, as much as it's important to ask that person, they're the experts, about their experiences and backgrounds, it's also really important for us to do our own research and to learn from that. So it's about us increasing our skills and knowledge through webinars, reading, robust conversations with everybody, and sharing case studies when it's appropriate. Point 4 there is really about those links to community members, leaders and groups to ensure that we can let them know about our services available, but also to learn, as I said, from them about how we relate to community members, what's the best way to link in and with whom. So that's that one. And just lost my points. Flexibility. So this was a big one for us, I think, and in relation to time and modality, a lot of our services are fantastic with the hours that they can provide service and the flexibility around those days and times that might suit people, to have a support person with them, to have an interpreter, or to have somebody that they just feel that they're meeting at a time that is relates and is respectful and suitable for them. Our new programs that we've had on board, so some of of them ahead to help. How do we ensure they support the CALD community? It's about tailoring COVID information messages to the community values and link with community connections that are already there. So for example, our Bounce Back Youth program works at the moment, and so do each, with Enliven, which is a fantastic organisation in Dandenong that works and has a lot of experience with our CALD community. I think too, our Head to Help program has ensured that we have a lot of brochures in a lot of different languages, making sure that we're providing those in the right place to community members and that they're accessible. And I just wanted to talk about the flexibility, and I'll include, because I know we're nearly out of time, flexibility in the last point, really ensuring that our programs are available to people, as I said, when they need them and with the services they need, whether that's an interpreter, and like Ellie's program, they really have a lot of experience with working with people and speaking second languages, which is fantastic for that trust, those trust issues. And I think the last point really was we really looked at our referral form. Now, a lot of the information we need sometimes is to ensure that we keep getting funded, so that non-identifiable information. But I think, as they said on that clip, it's really about what do we need, what makes a person feel comfortable, and yeah, so how much information do we really need? We actually changed our referral form, and after speaking with our different service providers and ensuring everybody feels comfortable with what we're asking them, and also providing clear, consistent messages across SEMPHN about what our programs can actually provide and how we can support people. And I'll leave it there because I want Ellie to have his time. Thank you.
Thank you very much, Liz, and thank you, everyone. And I would like to acknowledge and I guess and welcome everyone who's here, and a big salam alaikum to the ones who are here from, I guess, our CALD communities as well, who speak the language that I've just mentioned. So I'll go to, I guess, a quick introduction to the Connect program. We have already spoken about what the Connect program, I guess, is. If Jody could go to the my first slide, probably the slide after this, if it's okay, and then we'll come back to this. Yeah, so with the Connect program model, as we've mentioned, it is actually part of a stepping process or stepping model where Connect sits at the bottom, being the low intensity peer support mental health program. And then we've got EPI, and then we've got MEC. So EPI being accessible psychological intervention, and then MEC being the highest, I guess, model of service delivery for people with high intensity or I guess more complex mental health issues, and that stands for mental health integrated complex care. So when someone comes to Connect program, we conduct a K-10 assessment in that intake process, and then that somehow dictates, I guess, the direction, whether they are suitable for the Connect program or whether they need to be referred to a more advanced, I guess, level of care. And in that case, we would be communicating with our funding provider, Southeast Melbourne Primary Health Network, or SEMPHN, and Access Referral Team, and then they would make the decision on whether they are more suitable for an EPI program or the MEC program. But most likely, the clients who are referred to us are eligible for our service. So once, I guess, we conduct the work, and then as Atiq was stating in his video, one of our peer support workers, that it is based on a social model. The program starts on a medical model, but the way that we interact with clients is mainly has a lot of social aspects to it, and that's based on the huge, I guess, experience and expertise that our workers bring in the cultural and linguistic, I guess, diverse communities. That I guess gives them that tool to I guess work with the individual clients in a more culturally and linguistically, I guess, appropriate manner. So with the Connect program, the workers that we have, like what makes this program special, what makes it more different than any other program that provides, I guess, possibly a similar support. I guess it's the workers, it's the delivery method. So we have workers from different, I guess, diverse culture and of course, educational background as well. So currently we have workers with a Bachelor of Medical Sciences, a postgraduate in community development, also in the process of doing a Master's of Social Work. We've got a worker with a postgraduate in career development counseling, and also we've got a worker with background in nursing. So you can see that it is just not the language and cultural expertise, but it's also the huge educational and I guess and skills backup that they bring to this job. And then once I asked them, I said, look, I mean, you guys could get a job in any other field, possibly a higher paid job as well. It is the love that they have. It's the passion that they have for this work that actually somehow I guess encourage them to stick in and then to do this job. And then that's why this whatever these workers are doing and whatever I've been doing, I guess it comes from here. So that's why it makes it so special. And then when you connect with someone at that level, you can only guarantee one thing, that the service that you're providing is of a best of the quality. And I guess and then you touch people in a way that is, I guess, more genuine and more authentic to them. In terms of the approaches that we use, I guess it's as it was mentioned before as well, definitely client-centered, strength-based approach. We've had to use a lot of narrative therapy in the last, I guess, if you're going to compare it with a medical, I guess, terminology, in the last, in this pandemic period, because of, I guess, the complexity of issues that people were bringing in. So the reason for that, of course, is as everyone mentioned as well, that re-traumatization of the clients. Majority of our clients, and I would like to actually say a special thank to Haifa Kasamani. She was the ex-team leader of this program until February last year. She had a lot to play, I guess, a huge role to play in advocating for this program to be a more CALD or culturally appropriate program to our CALD communities. And we're really, I guess, inspired by the work that she has done for this program. So I would like to say a huge thank you to her. And part of the work that she has done was developing a strong relationship, or putting the foundations for a strong relationship with AMES Australia. Predominantly, probably around 80% of our clients came from AMES Australia during the pandemic period, and pretty much all of those clients were from their HSP program, which was the newly arrived refugees. Some of them just came in weeks ago, before the pandemic, before the lockdown. So imagine just being re-traumatized, being just having the same, I guess, experiences of being locked in a space where you are limited in your movement. And we, so if I give you a quick glimpse, like in the quarter before the pandemic, we had around 40 clients referred to our program. In the quarter after the pandemic, we had 110 clients referred to our program. Probably 90 of them came from AMES Australia in that first quarter only. So imagine 110 or probably 90 clients with 90 stories, 90 stressors, and a common theme was social isolation and re-traumatization. So we had to adapt to a service delivery that was actually meeting those needs, that was actually delivering to support those concerns within our client groups, and having somebody to not only I guess understand that, but also communicate with those clients in a culturally appropriate manner, to speak their language was needed, and that's what helped us actually go through that whole period. With what we hear from our clients is that yes, the medical system that we have now may not actually be the most appropriate one for our CALD communities. and that one of the main reasons that they're actually saying, presenting to us, the clients, is that we need to actually explain ourselves first. We need to identify ourselves first, speak our like try to draw a picture of our culture to these psychologists or psychiatrists, and then we need to talk about our issues, because without them knowing where we are coming from, it's not possible for them to provide us the most appropriate, service or care. When they speak to a Connect person, like a Connect peer support worker, that Connect peer support worker already knows where this person is coming from and already has a huge cultural knowledge, and that makes it easier for them to actually deliver a service that is meeting the needs of those clients. And if you go quickly to the graph in the first slide, Julie, it's as you can see that, I mean, it is from July 2019 to June 2020. Probably February, it's self-explanatory. From February onwards last year, the mode of delivery or service delivery actually changed, I guess, predominantly were by phone. Our clients struggle hugely with Telenet and like Zoom or any other platforms. So we had to strongly rely on phone communications. And then a bit that you see in the green, which is video, that is a group activities. And Connect was pretty much one of the only ones within our, I guess, area that provided a online group sessions to our clients during that pandemic. So I think that's pretty much from my side. So, thank you.
Thank you so much, Ali, and thank you to everyone for sharing all of your work. This is the opportunity for everyone to ask any questions of us or the panelists, if you want to put them into the Q&A section at the bottom of the screen. I think there was one there. Ali, if you wanted to, you did answer that one.
So that question from, is it from Katrina? Or is it? With the Connect program, it is funded for City of Greater Dandenong, but we have the flexibility of working with someone who is connected to the city, not just living there. So if they're connected by working in the City of Greater Dandenong, or they've got a family member there, or they're studying there, we can still work with them. With Shine, it is City of Greater Dandenong and KC, and to a certain degree, Cardinia as well. Now, we would hope, I guess, love to have an expansion as a result of the recommendations from Royal Commission, but that's definitely back to our funding providers. So Shine is a federally funded program, Department of Social Services, whereas Connect is funded by Primary Health Network. And Liz is sitting there.
So is there any other questions for any of the facilitators, Liz, Christina, Amanda, Ali? Pop them in the Q&A and we'll read them out and someone will respond.
Even if there's any questions about what came up for you as a result of the poll and what inspired your responses, and if you have any questions.
I think everyone's quiet. Maybe everyone's covered it all. Amanda, did you want to move then to the summary?
Yeah, sure. Just wanted to acknowledge some of the themes that have come up today. I want to acknowledge the discussion around the collective development of trauma-based disorders, including acute stress disorders and post-traumatic stress disorders and mental health burden that many of the providers and the panelists have discussed today that have been experienced by clients as a result of the COVID-19 pandemic. and the effective strategies put in place by the sector to continue to support the CALD community. So I just want to thank you all for discussing your work, and thank everyone here as a attendee as well. I just want to acknowledge all of the strategies that have been put in place to eliminate the stigma attached to the CALD community seeking support around mental health, and the massive initiative taken by everyone to mitigate that. Well done.
Amanda, I'm just going to share the numbers on the screen for everyone to see. Has everyone got that?
Fantastic. There is one question there. Is there a time limit for how long in Australia to be eligible for the Connect program? I guess that one's for Ali.
No, there is no time limit, and also Connect program is open to anyone and everyone. So if we don't have a peer support worker who speaks the language of that client who speaks for a language other than English, then we have access to interpreters as well, so they can that could be used as well.
Amanda, I'll move to the next slide. Oh. Amanda, maybe you or Ali can mention the Connect Online initiative that you're looking to deliver.
Sure, I'll give that one to Ali.
Sure. So we are actually planning a couple of sessions of online drop-in for our community members, our clients. So we are hopefully a survey that we might be sending to you guys would actually ask for some suggestions from you as well as service providers or community leaders. So we'll highly appreciate if you could actually provide your suggestions as well. But we are trying to, I guess, work on subjects related to mental well-being for within the community, and then our drop-in sessions would actually focus on that as well, on top of whatever that you guys are suggesting as well.
Thanks, Ali. Amanda, did you want to mention anything else before we sign off?
If you want to just bring up the last slide, and again, I understand quite a few people have to go, but I just wanted to really say a big thank you to everyone that made it, and apologies for those that didn't make it this morning due to technical difficulties. We'll send an email, I think, with the full recording of today's presentation. And yes, if you have any further questions, feel free to send us an email or contact any one of us, and we can ask further questions.
Amanda, I might leave it there. There was a question in the chat channel from, or the Q&A. I can't find it now.
We've got that one, Tony. No worries.
Have you got that? Beautiful. And there's also a comment from, oh, sorry, so many things, from Dakina from the Centre for Excellence. She's wanting to connect at some point about the research that they're doing. Amanda, last words? Anyone, last words? Liz, Christina, Ali?
I just wanted to thank everyone for being here. It was a bit of an emotional one as soon as I guess stopped watching the video. So I was trying to keep the emotions intact while doing my bit. So thank you again.
Yeah, I'd like to thank everyone for your time of being here.